Okay, well, welcome everybody. This is a nice crowd we've got. That's terrific. So I'm Dr. Amsel. I'm the Associate Director of GPEG, which is one of the sponsors of this conference. And I have today the honor and the privilege of introducing our speaker, Vladimir Carli. And Dr. Carli is an associate professor in psychiatry at the Karolinska Institute, which is in Stockholm, Sweden, where he is calling in from, and will give his talk from. Dr. Carli is an adult psychiatrist and co-director of the World Health Organization Collaborating Center for Research Training and Methods Development in Suicide Prevention. The Karolinska Institute is the home of that program, and he is the co-director. He's led or participated as a co-investigator on many multinational studies, including the Saving and Empowering Young Lives in Europe, which is the SAILI study, which my group was also very pleased to be part of. And that was a randomized clinical trial for suicide prevention in 11,000. I still think it's probably the largest intervention we think that's been done. It had some very significant reductions in suicidal ideation in that group. He's collaborated on many international studies, especially in the European Union, with the World Health Organization, including working on development of the suicide section in MHGAP interventions. He's also chair of the suicide section of the World Psychiatric Association and a major contributor to the suicide section of the European Psychiatric Association. With all that, I do not have any idea where he has time to come and give us a lecture because he's doing all of that. But Dr. Carli is a wonderful and charming speaker, and we are very pleased to turn the floor over to him.
Thank you very much for this very nice introduction, and thank you to the organizers of the meeting to invite me to speak here. Unfortunately, I couldn't make it to Guyana. I would have liked a lot to travel there, but I'm connecting from Stockholm in Sweden. That I guess it's very cold in comparison with Guyana right now. Today, I'm going to speak about an e-health system, which is called NEVERMIND, which is a system that we developed. This is also what I will show are the outcomes of a EU project that has been funded by the European Union. And this e-health system that I will talk about was developed during this project and then was also evaluated on an RCT in a clinical population. So we're not looking at numbers so large as the SAILI study. Moving, I have nothing to disclose, no conflict of interest to disclose for this presentation. So let's start from the background that was our departing point. You will see that our target group for the study were patients with severe somatic conditions. And that is because, starting from the evidence that tells us that the prevalence of depression among patients who have suffered from myocardial infarction, from chronic kidney disease, or suffer from cancer, it's very high. As you see, the percentages change pretty significantly depending on the studies and the regions of the world where they have been done. But we can estimate that at least 1 of 4 patients with a chronic somatic disorder does develop a depressive disorder, or at least depressive symptoms. And depression, it's a big problem in this context because it increases the strain, the overall strain felt by the patient, decreases their quality of life. But also, we know that depressive symptoms actually have a negative impact on the outcome of the primary disease. So it's not only that a patient with cancer suffers, in addition to the cancer, also from depression, but also that the prognosis for cancer worsens if a patient develops depressive symptoms. Now, the situation, at least in the EU, but I think that this happens worldwide, is that these patients with severe somatic disorders very seldom get psychological treatment or even a diagnosis or an evaluation of their mental health symptoms. So in the health systems, there is not an incorporated method to prevent the onset of mental health symptoms or to make an early diagnosis of mental health problems. And most of these people don't get any psychological support. And this is mostly due to lack of resources, where by that we mean financial resources, but not only financial resources, because in many countries, we suffer from a significant lack of mental health professionals. So even if the health system has the resources to treat the patient, still there are no health professionals available to offer the mental health support that would be needed. So with this in mind, we answered this call from the European Union. This was back in 2016, and this project was 5 years long. So it's basically ended at the end of last year. And the main paper was published in 2022, so this year. And the call was about self-management of health and disease and decision support system based on predictive computer modeling used by the patients themselves. So there was a strong focus on systems, e-health systems that are standalone and don't require the intervention of a health professional or require very little intervention. The title of this project was Neurobehavioral Predictive and Personalized Modeling of Depressive Symptoms During Primary Somatic Diseases with ICT-enabled self-management procedures. And NEVERMIND, it's the acronym that we found for this long title. And this project was funded by the European Union under the Horizon 2020 research funding program. So basically, what was the idea from this project was that we would collect a bunch of information and different kinds of data from patients. And that included a lot of physiological data. So the system consisted of a mobile app that was installed on a smartphone and on a smart shirt, which was collecting the ECG of the patient in real time. And we were mostly interested in the HRV, in the heart rate variability, because there are some studies that show that that's predictive of depressive symptoms. But we were collecting also other physiological parameters, like we were collecting the respiration rate, the activity and movement. We were monitoring sleep and stress. And we were also recording the voice of the patient. And then at the same time, we were also collecting mental health data. And the idea was to create this personalized system that was incorporating self-management of mental health and would give feedback to the patient, and also would direct the patient to different forms of support and care that were delivered by the system itself. So this mobile app, I will go into it later, was also able to deliver interventions to the patients, but the interventions were personalized to the specific situation of the project. And there was a real-time decision support system that was actually running locally on the patient's smartphone. And that was done because there were a lot of concerns about sending mental health data to centralized servers and so on. The system did actually depend on a centralized server where the physiological data was sent. And that was because the computational power needed for the analysis of the physiological data needed a more powerful computer. So basically, the patient had a smartphone and a shirt, and this was locally given to each one of them. But the physiological data was sent to this server, analyzed, and then sent back to the smartphone. And at the same time, the server was interacting through a backend, was also interacting with a medical professional that actually was able to fine-tune the interventions that were given to each patient. But of course, the workload was very low. So one medical professional was able to follow many patients at the same time. And basically, this was a very interdisciplinary project because there was a lot of technological development involved in it. And so we were working, I mean, there were different centers around Europe, and the coordinator of this project were some engineers from University of Pisa in Italy. And we were basically the mental health component of this project. And what was our task was to build a self-assessment tool for mental health. And we had some objectives in mind when we did this. And first of all, we wanted this monitoring to be continuous. So we wanted the patient, we wanted to be able to collect continuously information on their mental health. But we also wanted to have different levels of inquiry depending on the status of the mental health status on the patients. As much as possible, we wanted to use validated scales to measure a number of mental health parameters, such as depressive symptoms, anxiety, sleep quality, and stress. Then we wanted the system to be able to provide personalized feedback to the patients, and then to direct the patients to different levels of care, depending on their status, that were provided by the app without the intervention of a medical professional. So starting from these different levels of inquiry, the system basically was starting from 3 main questions that we were asking every day. So in the morning, every morning, the smartphone was asking to the patient, how are you feeling today? And how was your sleep? And then at the end of the day, it was asking, how was your day? And if the answer was negative, that means that they didn't feel so well, or they didn't sleep well, or they had stress during the day, then they moved to the second levels of inquiry. That meant that the system was asking them additional questions that you see in this slide. And in this case, we already made an effort to find individual item questionnaires that were able to evaluate depressive symptoms, anxiety, anger, and sleep. So basically, the second, regarding how the patients were feeling in general, the second level of inquiry included the questions: do you feel sad, down, or uninterested in life? Do you feel anxious or nervous? Do you feel angry? If they had problems with sleep for several days in a row, then there was an insomnia questionnaire that was administered to them. And if they were reporting stress during the day, then we were asking to rate the amount of stress that they were experiencing, but also their ability to handle this stress. And firstly, these questions, so the 3 main questions were asked to the patients every day, but we were also collecting all these physiological parameters. And the idea was that with machine learning algorithm, we would then be able to use only the physiological parameters to predict if the mood of the patient was worsening. However, I mean, for this, one needs to accumulate a lot of data. So in the beginning, what happened was that these questions were not actually asked every day to the patient, but the answer was replaced in some days by the calculations that were made by the machine learning algorithm. And then the system was also detecting what was the variance of the physiological parameters. And if the variance was increasing, then we would ask the question with a questionnaire, as we're doing here. And then there was the third level of inquiry. So if, according to this already validated single item question, the patient was showing depression or anxiety or insomnia, at that point, the system would administer to the patients a proper validated scale. And we were using the PHQ-9 for depressive symptoms with an additional question on hopelessness, because we know that that's an important factor for, so it's strictly related to, closely associated to suicide risk. We were using the Pikel suicide ladder to evaluate suicidal ideation. We were using the general anxiety disorder 7-item scale for anxiety symptoms. We were using the Athens insomnia scale for insomnia. And then we were using the stress component of the DAS, the Depression, Anxiety, and Stress scale, to measure stress. And we were also administering the WHO-5 well-being scale. And according to the answers to that the patients were giving, each patient was receiving personalized feedback. And in order to achieve that is that we structured basically the feedback in 4 main components, which were the name of the patient. So the patient was always called by name by the app. Then an acknowledgement of their status, depending on the answer on the psychometric scales. But then depending on the answers, we were also suggesting an action that in some cases could be just keep it up with just positive feedback. In other cases, it was take this other psychometric measure because according to the previous answers, we believe that's necessary. In some cases, it was an actual intervention. And then the 4th component of this personalized feedback was always a compliance statement, because of course compliance is of paramount importance in a system like this that it's standalone, because if patients stop using it, it's not effective, cannot be effective, of course. So each time there was an opportunity, we were trying to insert a statement to reinforce compliance and the importance of continuing to use the system. And then, as I mentioned, depending on their status, the patients were referred to 5 different levels of care. The first 4 of them were actually done by the system itself. So level 0 is when the patient was feeling well, they were just receiving positive feedback. Level 1, if there were some very initial symptoms, they were getting some behavioral and lifestyle advice. And this also included, this was about mental health promotion, but also included some advice about the primary disorder of the patients, because remember that these are patients with chronic somatic illnesses. Level 2, so when patient had mild symptoms, especially of stress or sleep problems, they could do online mindfulness within the app. And level 3, so that was when the patient showed moderate or severe depressive or anxiety symptoms, then they could access online CBT. And we use an already established and evidence-based system for this, that it's called Depressive, that was embedded in our system. So they could do online CBT within the app. Level 4 was when, after a few weeks of doing CBT, we didn't detect any improvement in the depressive symptoms. The system didn't detect any improvement in the symptoms of the patients, or even a worsening of the symptoms. And then at that case, the patients were referred to mental health care for treatment as usual. And then there was level 5, that's when there was severe suicidal ideation or acute suicide risk. And in that case, there was an emergency intervention that consisted in providing the patient with a safety plan and giving them information and resources about who to contact for a suicidal crisis. And at the same time, the treatment team was notified so that they could intervene. So this is what the smartphone app looks like. Take into consideration that it's a prototype. So now we're basically working to try to refine the design of the app. So there was these buttons here, they changed depending on what was the status of the system. So the different levels of care would appear here if the patient had symptoms or didn't have symptoms. So there was a section where we were giving basically tips and advice for their primary disease. There was the possibility to do mindfulness practice. Actually, there were two different kinds of mindfulness. There was one basic form of mindfulness that patients were able to do whenever they wanted while they were using the app. And then there was a targeted mindfulness towards anxiety, depression, or sleep that was activated when the patient had these symptoms. There was a daily recommended sleep practice that could pop up if the patient had sleep problems. Then there was this module that we called What's Up that basically included these daily questions about mood and daily life. And to this, we refer to these questions that I showed you before. How was your day? How was your sleep? And how do you feel? Then there was an activity monitor with recommended physical activity for the patients. And there was also a nutrition model with dietary advices for the patients. And behind this front end, this is what the patients were seeing. There was a rather complex flow of different actions that could happen and feedback depending on the answers that the patients were providing and depending on the physiological data. So now this is a bit complex to go in detail to each to show you all of it, but I will zoom in one part just to understand how the system was structured. So the Q1 was the question 1, how are you feeling today? And the patient was able to give an answer, we had a slider, and basically was able to provide an answer between 1 and 6, where lower was well, and 1 was the best possible answer, and 6 was the worst possible status. So if the patient scored between 1 and 3, the feedback that was given had these 4 components that I mentioned before, had a name, the acknowledgement that the patient was well. What the action was to send the patient to level of care 0, which meant only giving positive feedback. You're doing well, keep it up. And then there was a compliance statement. If the patient was if you see here, I hope you can see my arrow, the patient was providing positive answers that they were feeling well for 3 or more days, then the personalized feedback changed slightly. So you see here, we gave another kind of acknowledgement to reinforce the fact that it was many days that the patient was feeling well, and that was positive. The action was the same, was positive feedback, and also the compliance statement was the same. If at this first question, the patient was giving an answer that was, he said that he were not feeling so well, so the score was higher, then the personalized feedback was different, the acknowledgement was different, and was acknowledgement that there was maybe a problem. And the action was to to open these additional questions on depression, anxiety, and anger. And also there was a slightly different compliance statement. And then if the patient scored high on depression for at least 3 days in a row, then the patient was directed to take actually the PHQ-9, and according on the score on the PHQ-9, the patient was directed to the different levels of care. And the patient at this point would get also the Pikel scale to analyze suicidal ideation. So this is a bit what the system was about. And after developing it, what we did was to make a randomized controlled trial on a group of patients to test the effects of the routine use in a clinical setting of the NEVERMIND system in comparison with treatment as usual. And the study was 12 weeks long, so our primary outcomes were depressive symptoms, but into looking at treatment effects and preventive effects. And our secondary outcomes were self-efficacy, suicidal ideation, perceived stigma, and also sustained effectiveness after 24 weeks. Even if the patients were able to keep the system only for 12 weeks, we were following them up 12 weeks later, so that means 3 months later, to check if their effects were still sustained. This was the design of the study, so all the patients were analyzed for eligibility and consent, and then we made a baseline evaluation on them, and then they were randomized in the intervention group or the control group. As I mentioned, the intervention was 12 weeks long, and then at the end of the intervention, they have the follow-up evaluation, and then they had another evaluation at 24 weeks. And the control group basically had used treatment as usual, while the intervention group was NEVERMIND system plus treatment as usual. And these were the clinical center. It was a multi-center study. Basically, all centers that recruited patients were located in different parts of Italy or Portugal. And as you may see, we recruited patients with breast cancer, with prostate cancer, with myocardial infarction, with kidney failure, and with severe diabetes that led to amputations. The inclusion criteria, we took only adults, so subjects with more than 18, that were more than 18 years old. They needed to have a diagnosis of one of these 5 somatic diseases. They had to be proficient in the language at the recruitment site, and they were supposed to be familiar, at least familiar with using a smartphone, because due to the diagnostic groups, I mean, our age group was rather high, so it was important to select people that actually were able to use the system without major problems. And we excluded patients that had a past diagnosis of a major psychiatric disorder other than depression, those who were in current treatment for depression, and those who had cognitive impairment. And these are the psychometric scales that we used for the evaluation. So at the baseline and follow-up evaluation, so these are not the scales that were administered within the system. And to evaluate the system, we use the BDI-2 for depressive symptoms. We use the WHO-5 well-being scale, the Pikel suicide scale. Then we use a scale to measure stigma, self-efficacy, quality of life, illness perception, and we also collected some socio-demographic variables. And out of almost 1,200 patients that were assessed for eligibility, we ended up recruiting 425 patients that were randomized, half in the NEVERMIND group and half in the control group. And we had, as you see, we had a dropout rate of around 20% that it's acceptable for these kinds of study. We use block randomization to ensure that at each site there was an equal number of patients in intervention and control, and the randomization was carried out centrally by an electronic system. We were unable to blind the patients and the treating physicians to the treatment allocation because they were receiving the system, so it was physically impossible for them to be blind. However, the evaluators that administered the questionnaires and the clinical interviews were blind to group allocation. And these are the main results. So when the main outcome, as I mentioned, was the BDI score. And as you see in the first row of this table, the effectiveness of the intervention in comparison with control was highly significant, and there was a reduction in the BDI score. And this was adjusting for the baseline BDI score and adjusting for the social demographic variables, which were living alone, gender, and age. Gender was also effective, so it seems that the system was more effective in females in comparison with males. And then when we look at the secondary outcomes, we see that there was a significant effect in terms of reduction of suicidal ideation. PSS, it's the Pikel suicide scale. And we did find improvement. This improvement in depressive symptoms was lasting, was still evident at 24 months. And interestingly, when we looked at those patients at the subgroup of patients that didn't have depression when they were recruited, we have seen that in the NEVERMIND group, less patients were developing depressive symptoms. And this is a very good result in our opinion, because that means that the system not only has a treatment effect, but it's also able to prevent depression. So it's possible to use this system with people who are at risk for depression, but didn't develop it yet. Of course, there are strengths and limitations. The limitations are that we couldn't achieve complete blinding, and that we had these different centers, and treatment as usual was not standardized across the centers because they had to follow their own procedures. We couldn't analyze the different components of the intervention, and by this I mean the mindfulness or the behavioral part or the CBT, which one was effective, because we would need a larger sample for that. The secondary outcomes, I mean, if we correct all the results for multiple testing, we lose the significance of the secondary outcomes. And I mean, this study was done on a group of very specific group of patients. So now we're working to do another study, because I mean, we're really very keen in testing this system, not only on patients with severe somatic disorders, but to expand the study on other categories of patients, including psychiatric patients. The strengths were that the sample size was adequate according to the power calculations that we did, and we had low dropout rates. So conclusions, our system was effective in reducing depressive symptoms in the studied patient groups. The effectiveness is sustained at 24 weeks. The system was also effective for those who don't have depressive symptoms in actually preventing depression. We need further evaluation on other patients groups, and especially in patients with patients where the primary diagnosis is a psychiatric diagnosis. And also, I mean, these self-management systems are really essential to limit the burden on the health systems, and because these systems can be easily scaled up and given to a large number of patients. This was my last slide. Thank you very much. And now I'm happy to get any questions you may have.
So if anyone has a question, you can either put it in the chat, or you can raise your hand, or you can just shout it out. You can just start talking. It's okay.
I have a question, if I may, Professor Carli.
Of course.
Hi.
Hi.
You said females seem to benefit more than males, but I didn't. Was there a specific hypothesis to explain this? Because I probably didn't catch that.
No, because I mean, when we did the primary model to measure the primary outcome, we used age and gender as adjusted by age and gender as a standard procedure, and we found out that that gender was significant. So being female had an effect on the reduction of depressive
on the reduction
symptoms.
of this. Okay, all right.
Yeah. So it was an unexpected finding.
Yeah.
I can say that, I mean, because we're running also other studies in parallel about the usability and the usage as moderators of this. And one aspect is that, I mean, there are two aspects. One aspect is that females tend to use the system more in general. So to have a higher usage over these 12 weeks. And then also there is this group, we had these cancer groups which were a bit special, because we got breast cancer, which were only females.
Only females, yeah.
And we have prostate cancer, which were only males.
Yeah, okay.
So it also might be that there is an effect of the disease.
Okay.
Yeah.
Thank you.
Yeah, I have a question. Actually, it's a series of questions in one, packaged in one.
Okay.
What was your sample size to begin with? Second, when I look at the design of this app, I'm interested on the issue of confidentiality and protecting clients or the users' data or information. And the third aspect of that particular app, especially when I was looking at your flow chart behind the scenes, the behind the scenes design, is what happens if there is an individual who has selected that they're not doing well and may be on the verge of going into a crisis. How do you address for that? Is there some remedy to refer the individual to a therapist or connect them as soon as possible with a therapist to de-escalate the crisis if they're about to go in crisis or they're already in crisis?
Yes.
So there's three questions there.
Okay, I'll try to take them one by one. So the sample size was 425 patients that were randomized in the two groups. The second question I missed maybe, but let me take the third one first. So the third one.
The second question has to do with confidentiality and
maintaining.
Oh
yes, okay, yes,
maintaining
yes.
The respondent's privacy.
Yeah, that was a problem, of course, for us. So we tried to, I mean, let's say that the identification of the patient, that means personal data as name and address, was never sent. I mean, only remained on the smartphone of the patient. So we didn't get that information. Of course, there was a medical professional that those that were monitoring the study got codes because the data was pseudo-anonymized, and they could identify the patients and follow them up. But only those who actually were part of the study and were entitled to do so. But we were very careful not to upload not to use any cloud system or external server for the mental health data. And actually, we didn't even want to use it for the physiological data, but in that case, we had to use it because the files were too large and too complex to be analyzed on the smartphone of the patients. So the predictive algorithm that actually were trying to predict depression on the basis of the heart rate variability, and also we recorded speech. The patients were asked to speak in the phone, and we recorded their speech because there are some studies that have shown that it's possible to distinguish depressed versus non-depressed patients analyzing their speech, their tone of voice. But these are very large files that are complex to analyze, so this is not feasible it's not feasible on a smartphone. So in the experimental procedures, we had this server for the physiological data, but in the end product, where we hope to get soon, because we need an additional project, an additional funding to arrive to an end product that can be made available to the public. The objective is to try to minimize as much as possible the analysis of physiological data, to be able to do it on the smartphone, so not to use the external server. I mean, this was a prototype, you know, also the fact that we used a shirt. In the final system, there will be a band. There is no need to have a shirt. So, I mean, the final system will be, we will try to simplify it. And regarding confidentiality, I don't know if I'm answering your questions. I mean, the idea is that this will be a system that will be self-contained on the phone of the patient.
My question, the other part of the question is related to crisis management.
Yeah.
So if someone is experiencing a crisis,
yeah, we have that. I mean,
how are they going to be addressed?
Yeah, I mentioned that we had this level of care 5 that was an emergency procedure. So basically, that happened if the patient was reporting. I mean, they went to these different levels of inquiry and were reporting high scores of depressive symptoms at the PHQ-9. At that point, they were administered also the 4 questions about suicidal ideation. So if they had death wishes, they were thinking about death, if they were thinking about suicide, and if they had a plan. If the situation was considered to be acute, then the treatment team would receive a notification so that they would check in on the patient. And at the same time, the patient would get information about who to contact, like the national hotline for suicide prevention. And there was also some sort of safety tips. I mean, it was not really a personalized safety plan, but they got a number of advice regarding how to make a safety plan. For example, removing contact, being in touch with a family member, and removing any suicidal memes and things like that. I mean, that's the extent to which was addressed.
I was interested, Vladimir, in this idea that you seem to be saying that, which I guess is somewhat new to us, but has been a developing idea, that the somatic illnesses and the psychiatric illnesses each serve as a risk factor for the other. The untreated mental health will worsen the cardiac and untreated cardiac. Could you say a little bit more? Because we've been looking for the mind, the mind-body connection in psychiatry. People have talked about it for many years, but there's been very little science until recently.
Yeah, I mean, there is some research. I think the research is mostly in cancer and myocardial infarction, where it has been seen that depressive symptoms actually worsen the prognosis of the somatic disease. So basically, if you compare 2 groups that had myocardial infarction, and you compare those with depressive symptoms versus those without, those with depressive symptoms are more likely to have a relapse. And the same has been observed with the progression of cancer. So basically, it seems that good mental health helps with the slowing down, or at least in that, let's say, put it the other way around, that mental health problems tend to aggravate the diagnosis of the primary disease. And I mean, that's pretty striking. And of course, then there is the issue that mental problems add up to the primary disease. So if you have a somatic disease, on top of that suffering, you also get the psychological suffering, which in some cases it's even worse. So doing something for the mental health of these patients is extremely important. That's why they were chosen in this case for the RCT, and also because they are at high risk of depression. So, for example, when we had the recruitment, we estimated that within the study period, at least 1/3 would develop depressive symptoms. And then we found out that the number was actually more, in the control group was almost 50% that developed depressive symptoms, while in the NEVERMIND group, it was less than 30%.
Interesting. And are you conceptualizing this as a behavioral thing? So people with depression are not taking good care of themselves, or do you see it as a more of common sort of physiological processes, or is that yet to be discovered?
I mean, I'm not aware of research exactly answering this question. I would say, in my opinion, it's a bit of both. It's a bit of both. I mean, of course, probably the depressed patient doesn't take care well enough of themselves. And at the same time, there is also might be a biological connection.